I think most of us know antibiotic stewardship, and there is a fluid stewardship, and also there is a nutrition stewardship. Before starting to talk about nutrition stewardship, we will take a look about the antibiotic and fluid stewardship. Both of them are with 4Ds. First of all, drug. In antibiotic, the drug of choice, broad spectrum or not broad spectrum activity, and fluids. Are we going to use the fluid hypertonic or not hypertonic, isotonic, or which type of fluid we are going to use? And we are talking about is it appropriate therapy or not, combination therapy or not, and the classes of spectrum of antibiotics and the appropriate timing. After drug, there is a dosing. We, as Dr. Layla said and Dr. Heba, they talked about pharmacokinetics and pharmacodynamics. Fluids and antibiotics are having different pharmacokinetics and pharmacodynamics and also toxicity. Duration of action, when we are going to start and when to stop, and de-escalation through monitoring of both antibiotics and fluids. In antibiotic stewardship, there's 5Ds: diagnosis, drug, dose, duration. Which are we needing this antibiotic? Which bacteria is susceptible to this antibiotic? What is the recommended dose and what is the duration needed? And how to stop or shift or to another route of administration. What are the benefits? Increasing patient outcome, decreasing antibiotic resistance, and decreasing the cost. And this is very important to decrease the cost. It's a major job for pharmacists that they are a partner in the regulation of antibiotic stewardship in all hospitals these days. And first of all, we have to stick on documentation. What you didn't write, you didn't do. And this is a problem for us to write. And all of us are battering from those of quality, but as they need to write all things we have do. And also pharmacists will deal with intravenous or oral adjustment, dosing adjustment, optimizing the dose, and duplicate therapy, stopping of any one drug-drug interactions. For fluid stewardship benefits, they are managing fluids as a drug. What are the indications for fluid using? They are saying that there are 4Ds for drug, which are the drug selection, duration, and de-escalation, using arrows, 4 phases arrows, which is resuscitation, optimization, and stabilization, and evacuation using these fluids. The benefits, we have to ask when to start and when to stop, when to start removal of these fluids. These are questions to be asked for the patient. For stewardship of nutrition, what is it? It's an ongoing effort by a healthcare institution to optimize artificial nutrition in order to improve patient outcome, ensure cost-effective therapy, and reduce the side effects. It will gain a reputation if the concept will spread on various hospitals and according to the guidelines. What are the main essential elements for nutrition stewardship program? Malnutrition. Malnutrition is considered the key element in reducing mortality and duration and mechanical ventilation and hospitalization. In particular, these patients who stays in hospital for more than 7 days. What are the complications of malnutrition we can see in our hospitals? If your patient is on ventilation, weaning from ventilation will be too difficult as muscle mass will decrease. Our patient will become more fragile, fracture, bed sources, immunity decreasing. All these complications will result in increasing cost, increasing length of hospital stay. So our main issue is to decreasing this malnutrition accompanied by any on admission of this patient. A current meta-analysis with 20 studies involving a large number of patients, percentage of malnutrition between them ranges from 38% to 78% by using different tools. This is a study was done in Ayadi al-Mustaqbal Hospital in Alexandria, recently published in Supportive Care of Cancer. I was in this study, and the main result of the study is that the prevalence of malnutrition risk, that's mean we are talking about patients are malnourished or at risk of malnourished, it is 74% within the normal ranges worldwide. Using different types of screening methods as subjective global assessment can be used for cancer patients, and must screening can be used for outpatient clinics or inpatient. We have to know that all of them are sharing in 4 main questions. The first question is to ask is, what is your body mass index? Alone, body mass index can't indicate anything. These 2 pictures with the same body mass index. So we have to ask a second question to relate it to the body mass index, which is, what is the weight loss during the last period? But not any weight loss. We must say unintentional weight loss. If we are making a diet, so we are decreasing weight, but we are need to this. But we have to ask about unintentional weight loss and relate it to the disease condition, and asking for the dietary habits and how much your patient is taking food. After this gathering and submission of this score will result in the stage. Weight loss is a very common in cancer patients. 50% of them at diagnosis with weight loss, and 85% will develop malnutrition during treatment. Involuntary weight loss result in a decreased survival by 5%. All types of treatment, either chemotherapy, radiotherapy, surgery, are affecting nutritional status by decreasing the oral intake or by any method of these: fatigue, nausea, oral mucositis, constipation, or loss of appetite. By decreasing weight by 10%, we will suffer with increasing mortality 10%. By decreasing the weight, the loss of weight to 40%, we can reach 100% mortality. That's mean by increasing the weight loss, there is a increasing mortality rate. What are the main complications that accompanied by this decrease? For only 2 to 5%, performance status decreased, increased fatigue, decreased quality of life, increased therapy toxicity, increased risk of dose modification, overall prognosis and survival will decrease. Another element, which is, it's important to initiate enteral feeding early through nasogastric tube or percutaneous endoscopic according to patient state. This pyramid we have to follow. The baseline of our indication is oral feeding, insisting on oral feeding. If your patient is not taking his total needs, so we have to start to initiate enteral feeding. If it's impossible to initiate enteral feeding, we have to proceed to parenteral. But we have to stick to the order. Do not jump anyone over other. Starting by oral feeding and as the GIT is function. And this is our feeding pathway or tree map, which says that, is the GIT functioning? If yes, we have to use it orally. Less than 75%, we have to use tube feeding. If it's either long term or short term, we will go through either nasogastric or using percutaneous endoscopy. If we are failed to use to the GIT of the patient, we can shift to parenteral nutrition, either short-term or long-term, either central or peripheral. What are the main 6 Ds of the nutrition stewardship? First of all is diagnosis. As we mentioned, on admission, we have to diagnose our patient. Is he malnourished or at risk of malnutrition or well-nourished? Through screening and assessment. Screening, as we said, a very simple tool, not taking any time, anyone can do it, not, in a very, very simple way, only 4 questions to be answered, then go through assessment, which is more complicated. Simply, it's 4 items, A, B, C, D. First of all is anthropometric measurements, which including all patients' weight, height, mid-upper circumference, using a caliper for skin folds, and B for biochemical data, and C for clinical observation, and finally D, dietary history and drug history should be taken for our patient. Second, D for drug. They are treating or talking about nutrients, as they are chemical intelligence, and they are found in each step of the metabolism of in body. We will find that certain vitamins, certain trace element, any micronutrient, electrolyte sharing in this step. So it's very important to know that nutrients are drugs and should be administered in certain doses, like medications. Example, arginine. Arginine has 2 pathways. One pathway for proline, and this is benefit for wound healing. And the other pathway is producing nitric oxide, which is a vasodilator. If our patient is suffering from cardiac disease, it's a beneficial for him. If he is going on a surgery, it's well and good. But if your patient is on a sepsis or going on a septic shock and unrecorded blood pressure, bradycardia, if introducing arginine will worsen the condition of your patient. So we have to know that arginine is contraindicated to be given for patients suffering from sepsis or septic shock. As they said before, pharmacokinetics and pharmacodynamics for drugs. Also, there's pharmacokinetics and dynamics for nutrients. Ingestion. If we are not ingesting food well, it will absorb it well. Ingested, as the Dr. Haba said, with food or not with food. There are some people taking supplements as vitamins. Is it recommended to be taken with food or not with food? Example, vitamin D. Is it taken with food or not with food? It's a fat-soluble vitamin. It's preferable to be taken with a fat meal to increase its absorption. Iron supplement with food. With food, well, without food, it's increasing absorption. And if we taking vitamin C with it, it will increase absorption. Yeah. So ingestion have its calcium supplements.
Avoid milk containing.
With calcium? With food or not with food?
With iron.
Yes. If we are going to use calcium as a calcium supplement, so it should be away from food. If we are going to use it as a phosphate binder for renal patients, with food, to bind with phosphorus in the meal. In absorption, patients with short bowel syndrome can take vitamin B orally. It's not absorbed. So we have to change the route of administration. Now there is a sublingual vitamin B methyl technops يعني it's يعني marvelous. When we are going to take about metabolism, if the liver is not sufficient effective, we can introduce all types of amino acids for our patient. No, we have to choose. That's why we are considering our nutrient as a drugs with all the pharmacokinetic parameters. D for the dose. It says a poison. If we increasing doses more than we need, our patient will suffer. Our patient is starving, is not eating for many days, and he is admitted to the hospital. We didn't take from him any history. We didn't ask when he took food, what the amount of food he takes, and we are calculating the total amount of energy. 25 kilocalorie multiplied by the weight of our patient will result nearly 2,000 kilocalorie we administered to him. But our patient may suffer from a refeeding syndrome because he is not taking food previously. Electrolyte balance is not adequate. Phosphorus level is very low. He is not thiamine, vitamin B1 is very low. So if we give that normal amount of nutrient for this patient, he can die from the refeeding syndrome. So we have to know our patient how amount of these calories can be taken before administration to prevent the risk of refeeding syndrome, which is a fatal cause. And many patients in ICUs die from refeeding syndrome, and nobody knows that the cause of death is refeeding syndrome. They think that he needs nutrition, they are nourishing him. To know how to prevent refeeding syndrome, we have to stick to this. Start low and go slow. And this curve illustrates what this means. Starting by 25%, after 2 days, 50%, after 4 days, 70%. By the end of the week, we will reach the total needs for our patient, and safely he will tolerate this amount as his electrolytes is adjusted and his phosphorus level is correct. Glutamine. Glutamine is a conditionally essential amino acid, which is needed in large amount in stress condition and during critical illness. We are taking it from every food, but in stress conditions, the need is more. It has many functions. The main function is that it is the main fuel for enterocytes lining the GIT. There is a study was published, redox study, a randomized high dose of glutamine and antioxidant in critically ill patients. What it says, the result is most glutamine and antioxidants are harmed with patients with multi-organ failure. Before administration of glutamine, we should monitor liver function and renal function that they are within normal range. If they are not within normal range, it's not a benefit effect to be added, or we sometimes, if it's needed, we have to subtract it from the total amount. No? We have to subtract it from the total amount of the proteins administered to the patient, and أنا ما بحبش الستادي دي. أنا حاضر. The duration, when we are going to start feeding for our patient, we have to know that we are starting gradually by any method of these, enterally or parenterally or orally. Descalation, we are, when we are going to stop, we have to stop gradually. If we are in high in parenteral nutrition, we have to decrease it gradually and increasing enteral nutrition or oral nutrition, so our patient taking his total needs. During discharge, we have to know what is the plan, nutritional plan he is going to take through enteral and parenteral or supplemented parenteral. 2 slides. Finally, nutrition stewardship is characterized with a coordination to optimal form of nutrition, dosage, duration, and highest therapeutic result to avoid side effects or adverse effect and decreasing cost, and the 6 Ds as we said them. Implementation of nutrition guidelines that is very essential to stick to the guidelines, and the guidelines are recently changing every now and then. We have to stick to them, and thank you.
شكرا دكتورة دينا for this excellent presentation. And now يعني anyone have a question? اوكي طيب اسمحوا لي انا يعني مش اسئله، يعني هي comments واسئله.